This will be a long arm cast. I'm going to do one in plaster and one in fiberglass. Again, I'll start off with stockinette, although you don't really need stockinette to do a cast, but it does make things look a lot nicer. Most of the time, patients with this will be a supracondylar fracture. It could be a both bone forearm fracture, green stick fractures, distal radius fractures. Very, very common. Some people pre-cut that for the thumb. I always make sure. Some people don't cut this out. I like to. "90 degrees, slight pronation, no radial or ulnar deviation. 15-20 degrees of dorsiflexion." I'm going to bring her out to the side so you guys can see how I roll this. This first one will be done in plaster, or I'm sorry, fiberglass. You can use 2 or 3 inch cast padding, depending on the size of the arm. Try not to make any wrinkles in your padding as you roll it. Two to 3 finger breaths or widths from the axilla. 2 to 3 layers of padding. Certain areas get a little bit more attention. The bony prominences, the olecranon, radial ulnar styloid. You can use 2 or 3 inch fiberglass as well. Fold through the web space first, then I cut through it the rest of the time. Again, that is, I'm not here to tell you have to do it a certain way. Areas that break down in this cast is going to be the elbow. Seeing it from this point of view, you can kind of really see how she's slightly pronated. It's not a lot, it's just enough to where they can't see their palm. I like to angle the cast up and then back down towards the axilla. Back my stockinette. Again, padding way beyond the borders. And that they can make sure that they can bend down their metacarpals or their MCP joint. Good, I'm liking it. money roll. I am trying to get at least cover the whole cast with my money roll. I fold my fiberglass away from the patient, especially in the palm. Done. I hold 60s handshake, make sure I get my position. It's vital that you roll these things fast enough that you can make minor corrections while the cast is drying. 90 degrees at the elbow, no radial ulnar deviation, slight pronation. Again, green sticks, both bone forearms, supracondylar fractures, distal radius fractures, very common in a long arm cast. We're going to do a long arm cast in plaster over there on our other arm. Once this is dry, I can let her go. Also, what I like to do is, as the cast is drying, is put the cast in the position where the patient's probably going to be resting it most of the time. And that just allows the soft tissues, especially up in here, to adapt to the cast, or the cast to adapt to the soft tissues. If you roll a cast in this position and then move them over to there, it twists the soft tissues and they don't tend to like it. I am holding it in this position so that you guys can see it a little bit better. And I will do a long arm cast in plaster on the other side. Again, I like to trim out that little leftover stockinette in the antecubital space. Hopefully they can see this. I'm going to briefly pause, make sure that this is being captured on video. And it is not. And now it is. Again, no different from what you just saw. The main reason why I want to show in plaster is because you do need, or you should, incorporate splints at the same time as you're rolling. Again, a little extra padding around the olecranon. Radial ulnar styloid. Okay. I'm going to bring the bucket of water a little bit closer. Now again, I like to dip all my plaster in at one time. This is a lot messier. plaster, you don't roll it on so much like a spool. You more kind of push it and pull it on. Okay. Pull it, push. I do a quick lamination. I throw a posterior splint on because, again, the elbow is the weakest. It is only 2 or 3 layers thick. It doesn't have to be your typical 8 to 10 layers. I fold back my stockinette. Make sure I have plenty of padding again on each border. I do not want plaster up against the patient. Plenty of time. This is my money roll. I want to make sure I really pay a little bit of attention on how I make this look. Done. 60s handshake, nothing you haven't seen before. Again, these are neutral positions. Not every cast is going to require this position. It does depend on the injury. I try to laminate always the same direction. I have slight pronation, no radial ulnar deviation, about 20 degrees of dorsiflexion of the wrist, maintaining 90 degrees at the elbow. Plaster, long arm cast. Fiberglass, long arm cast. Still plenty of time. And we wait. Long arm cast, plaster, and fiberglass.